Often referred to as a silent epidemic, chronic wounds affect approximately 6.5 million people in the United States, and the numbers are growing rapidly due to an aging population as well as the increasing incidence of many chronic diseases. Today, we're going to meet with physicians on the front lines who are working together to change what have historically been dire outcomes, and how living cell technology is offering innovative solutions. I'm Olga Villaverde. Access Health starts right now.
My condition started 5 years ago. I guess driven by diabetes initially. I was mowing my lawn and the blade, it wasn't cutting, so I decided that I would change the blade on the mower. And the mower deck just happened to fall on my foot, and that became infected. 3 days later, when I was going to the hospital, by that time it was red and black. The surgeons there immediately tried to anesthetize it and give me all kinds of antibiotics and stuff, but it was so infected that that ultimately they had to carve out the skin that had blackened, and it left the wound about this big. It's terrible. You know, it's something you have to tend to every day. You have good days, but you have bad days. When the infection occurs, your foot starts to hurt. It starts to hurt to the point where you can't walk on it. I had my toe amputated. This is after I had gangrene on the foot at least 3 times. It couldn't be saved because osteomyelitis set in on the bones, and it was traveling up my foot. So I had a choice to make. You know, I'm always cognizant of the fact that if I develop an infection, that could happen again.
Vascular diseases are a primary causal factor leading to lower extremity amputation, accounting for 82% of amputations amongst diabetic patients with foot problems. Dr. John Lantis is the Chief of Vascular and Endovascular Surgery at Mount Sinai West in New York City. He's a founding member of the American Board of Wound Medicine and Surgery, and his clinical practice is at the forefront of lower extremity wound healing and tissue repair.
Here at Mount Sinai West, which is in the middle of Manhattan, we see patients with diabetes who have wounds. We see people who have venous leg ulcers who have wounds. We see people who have also inflammatory conditions such as Crohn's disease or rheumatoid arthritis, maybe sickle cell disease also, who all have wounds. So a very divergent population. Wounds are very multifactorial in why they occur. And they often have to do with the wound itself, they may have to do with the vascular supply, and they may have to do with the patient's underlying conditions, their nutrition, even how they walk, for example. The most common type of ulcer that occurs due to vascular disease in most people's minds is probably the diabetic foot ulcer. And that's an ulcer where there is lack of circulation to the foot and also lack of nerve conduction or sensation or feeling in the foot. The next one is the ischemic ulcer, which means that you're not getting enough blood flow to the foot, and you may well not be diabetic, and those are often very painful. And they occur usually in folks who've smoked, folks who have high cholesterol, and folks who've lived a very long time. And then finally, a separate type of vascular disease that occurs is the venous ulcer. And this occurs in a patient who doesn't have very good return of blood from their foot. And that can be someone who has varicose veins, it may be someone who's fighting obesity, it may be someone who's had a previous blood clot. And those can be very, very painful and difficult to heal. One of the things to think about is that you not only have to heal the underlying condition, but you also have to heal the tissue. And you have to choose what you do and how you heal that tissue based upon why they have the wound in the first place.
Coming up, the impact of a multidisciplinary approach in the management of chronic wounds. We'll be right back. since the majority of chronic wounds present on the lower extremities, and due to the increasing number of people with diabetes who have subsequent foot problems, the specialty of podiatry has propelled to the front lines of the wound care epidemic. Dr. Vicki Driver is the medical director of the Wound Care and Hyperbaric Centers at Innova Health System, a cornerstone in advanced wound care.
Innova has a very deep interest and support for patients that are at risk for limb loss and have wounds anywhere in the body. What happens with these chronic and terrible wounds, what happens to these patients is their life is put on hold. They are often ashamed and prevented from going to work, but are often thought that they created this problem themselves. It's not well understood that these are symptoms of other diseases that cause these horrendous areas of skin loss. Most of our evidence and our profession defines it as a wound that doesn't heal in an orderly fashion over about 4 to 6 weeks. Risk factors could include heart disease, cardiac disease, diabetes, and of course, is there adequate blood flow to the area? In order to save limbs and save lives, we have to develop better educational programs that reach the patient to help them understand that there are options, that there are centers of excellence, that there's wound care centers, that we now had advanced therapies available to them. But more important than that, we need to come together as a community, come together as specialists, work together collaboratively with patients. One discipline doesn't work to solve these problems. They're way too complicated.
I had a little cut on my my little toe, like the size of a pencil tip, and but it hurt. And I went in to see a podiatrist. He wanted to do surgery on my little toe. He basically just cut and cut and cut. When the nurses came in to change my bandage at home, there was a bone sticking out of my little toe, and it was just in horrible shape. So that's when I decided to go downtown to see another podiatrist. On that foot, I had a vascular intervention down my leg, but then it all healed after that, and I've been fine with it since then. I was hesitant to go to the doctor for my left foot because of what happened to my right foot. I just didn't want to go through it again, and I thought in my mind that I can take care of myself. But then I soon realized that it wasn't going to be okay. I'm just being stupid. Go to my doctor and get checked out and see what they can do with it. I didn't want to lose my foot or my leg.
So tell me how your drive-in was today.
My drive-in here was, well, I'm the rider. She's the driver.
The most important piece of assessment is, of course, to start with the entire patient issues, all of their diseases, get a good diagnosis. What type of ulceration are we treating? What are the components? What is causing it to be chronic? What are the conditions that we need to address, and in which order? For example, a patient with a leg ulcer, we should be looking at vascular disease. Are they diabetic? Are they immune compromised? Is the wound infected? Did it start from trauma? It could be pressure related from neuropathy. It could be that the patient doesn't feel their feet, which many diabetics don't. Patients hide these wounds not because they want to hide these wounds. They don't know anybody wants to see them. So it's important for us to assess, but it's important for us to explain what we found very clearly and educate multiple times. Once it becomes a problem for a diabetic patient, they have one sore, the likelihood of them developing another sore is very large. Unfortunately, many heal a wound and then get another.
Coming up, driving change with the development of new and novel approaches to wound healing. Before the establishment of dedicated wound care centers, patients would receive wound treatment from the specialists they visited, typically without careful monitoring and oftentimes with minimal facilities and resources available for advanced care.
There was a small sore on my foot, and it was kind of like it wasn't real painful, but it was nagging me. So being a diabetic, I said I need to go to the doctor and check it out. So I went to a podiatrist They eventually realized that it was a blood flow issue, and they referred me to a vascular doctor.
Tissue cannot regenerate without adequate oxygen to it, and the way we get oxygen to our tissue is by blood getting to it with oxygen carrying capacity. And therefore, if you have an ulcer that is there in part or entirely because you don't have enough oxygen to it, you have to get blood back to it to get it to heal. You have to open up all the blockages from point A to the ulcer itself to improve circulation. There are numerous interventions that can be done inside the artery. The simple terms are a balloon angioplasty, which involves just inflating a balloon. Now, in this day and age, that can involve using a drug on that balloon that helps to stop recurrence of the narrowing. There's also stenting, which is placing a metal stent depending on where in the artery and the indications. And that stent may or may not have a drug on it also to prevent recurrence of stenosis or narrowing of the vessel. And then finally, the term that comes up is atherectomy. And atherectomy means that a device was used that actually cuts some of the material out of the artery, the hardening of the artery, or the atheromatous plaque as we refer to it, and pulls that out of the artery itself. So those are three of the techniques that are used, and they can all be used in combination with each other.
The vascular doctor first tried angioplasty and put stents in my leg. The sore started to heal, but then I got a sore on my right foot.
I think she had it for about a year before I found out. I didn't even know her wound was that bad. Her whole heel was almost completely gone. She feels like I work so much that she couldn't tell me. And I take on a lot of responsibility, but I wish she would have told me then. Because I would have been, just like I'm doing now, I would have been rushing her to the hospital, taking her to doctor's appointments, making sure she gets the care that she needs. The first time I went to the doctor's appointment with her, the doctor walked in the room and he pretty much said, put his hands up, and he said, there's nothing I can do. He didn't even want to touch her. He didn't even want to look at her.
And he recommended amputation. I'm an ex-federal police officer, so the thought of me without legs, that really hurt.
And I kept telling my mom, you have to get a second opinion. And that's when she found Dr. Driver's office. And Dr. Driver accepted us the next day. And she felt her leg and she said, oh my God, your leg is cold. She didn't go into panic mode. She just said, I'm gonna refer you to another doctor and we're gonna save your limb. When you go from one doctor that doesn't even wanna touch you, doesn't even wanna look at you, and then you go to another doctor that treats all their patients the same, it was so quick with her response. She didn't hesitate. After she seen the vascular surgeon, we came back to Dr. Driver. She was impressed. My mom had blood flow. She had blood flow, and all of a sudden, this left heel was healing. It was healing. And then the right heel started going down.
Wound healing can become delayed due to a number of patient or wound-related factors such as diabetes, malnutrition, and peripheral vascular disease. At the cellular level, these factors inhibit production and release of signaling molecules to the wound bed. If these cellular components are not functioning properly, this can give rise to other factors that ultimately stall healing. Thus, a vicious circle can develop, which requires the use of advanced cellular tissue-based products that contain necessary components to support healing and move this process along.
There are a variety of advanced wound care modalities, and some of these are exogenous therapies, which may be things like negative pressure or ultrasound or electrostimulation, etc. And they all have their place, but the ones that are used the most readily are most likely what we think of as cellular or tissue-based therapies. The idea of tissue regenerative medicine with or without cells has really been a huge breakthrough in the last 25 years. They allow the patient to get a jump start on that healing process.
Coming up, using tissue regenerative technology as an approach to healing. A variety of strategic approaches are widely used in the treatment of chronic wounds, but the common denominator remains. In the event of wound healing failure, physicians are looking for advanced treatment options to offer their patients.
Patients who have had standard of care, good standard of care, debridement, offloading, maybe total contact cast, and yet they're still not healing, we would start thinking about a cellular tissue product or a cellular tissue, a graft, a skin substitute. Now, when do we reach for those? Not only when a wound is not healing for 6 weeks, but also when we have a patient who has a significant wound who is at very high risk of infection. These tissue products have been a very important part of our practice. They really give patients hope because there's a lot of science. If patients are into it, we can talk to them about, and we can explain how this works with their pathophysiology, meaning how this actually helps diabetics, because we know diabetics have some sick cells that are related to their skin, fibroblasts. Well, some of these tissue products actually have living fibroblasts.
Organogenesis has been on the front lines of advanced wound care for over 2 decades, leading the charge in developing innovative regenerative tissue-based technologies. Their comprehensive portfolio of skin substitutes and other regenerative medicine products empower patients with life-changing solutions, helping them successfully take control of their wound healing environment. One of their leading technologies, Apligraph, is a living cellular skin substitute and is used as an alternative to the patient's own skin. It is bioengineered using the latest advances in regenerative tissue-based technologies and is comprised of an epidermal layer and a dermal layer that look, respond, and function like healthy, normal skin. Apligraph plays an active role in healing by providing to the wound proteins normally produced by healthy skin, which are all important for healing. Our patients today were all treated with therapies from Organogenesis. The hope for healing is in the results.
Because I had really an open wound on my heel, the skin graft was the best alternative for this. I'm shocked that I'm even able to keep my foot. That it's healed now and everything looks good. I had no idea it would look this good.
I don't think of the doctor as just somebody there to treat the wound. It's somebody that I've partnered with to manage my health. You know, even though I'm still not 100%, I'm healing because of the new skin grafts that I got, and that gives me hope.
I do think that most of the time when I talk to a patient, I try to tell them that we're in this together. It is their foot or their leg, and they're going to have to do what I ask them to do. But I care a lot about succeeding here as well, because I want them to be better. So it's a partnership, and sometimes it can be very discouraging for the patient. It can take a long time. So it's important to be honest, but it's also important to be supporting of the process that they're going through, this road that they're going through to healing, and explaining to them how they're also going to stay healed.
So they put these grafts on her heel. The graft blended in with her skin, and it looks beautiful. When you look at it, it just looks like it was never a wound there. If you're walking around, you have wounds, don't hesitate.
With Dr. Driver, she gave me hope to be able to keep my legs and get back on my feet and be independent again.
This is really the importance, is to educate our patients, work one hospital at a time to develop these programs that can help patients and work collaboratively together, not just to heal the wound, by the way, but to get the patient all the way back to their life.
I'd like to thank all of our guests for being on the show. If you'd like more information on the subjects discussed today, visit organogenesis.com. And as always, you can visit our website, accesshealth.tv. We'll see you next time.